You're listening to Rise Above, a Rogers Behavioral Health podcast, where we sit down with Rogers experts who are changing the way the world views mental health and addiction. Obsessive-compulsive disorder, or OCD, is common enough now that the phrase, "oh, I'm so OCD," or "oh, that's just my OCD taking over," gets thrown around. It's really a common thing to say. But I think a lot of people, when they say that, they don't really realize what obsessive-compulsive disorder is. And what it is it's a real challenge for parents of kids that are struggling, for anyone who's struggling, really. It can be overwhelming and can probably feel pretty lonely. But the good news is, if you are struggling, if you have kids that are struggling, you're not alone. So in this episode, we wanted to talk about some strategies that parents with kids struggling with OCD can take in order to help, maybe even some signs that a parent can look for to maybe, catch that OCD diagnosis early. And to help me with that is Dr. Martin Franklin, Executive Clinical Director of OCD and Anxiety Services at Rogers Behavioral Health. Dr. Franklin, thank you so much for joining me.
Happy to be here.
I know you've spoken about it, you've written about it, but let's just, from the top, most basic level, what is obsessive compulsive disorder?
Sure. I'd say that it's characterized by unwanted and intrusive thoughts or images that the person doesn't want to have. They like to get rid of them, and they make attempts to get rid of them. And these attempts are called compulsions. So either behaviors or mental acts. The classic example in OCD is a person who's afraid of getting contaminated or fears that they have been. And that's the obsessional side. They get worried, they get fearful. Sometimes they're afraid of a feared outcome like getting sick. And then they do the repetitive behavior or mental act to reduce the likelihood of getting sick or to reduce their anxiety. And in that case, the classic example is I touch something contaminated, I go and wash my hands. There also are kids and adults who will engage in mental rituals. So I touch something contaminated, and then I reassure myself over and over again that this is not going to lead to these bad outcomes. And it sounds to most folks, it sounds like trying to get rid of one's anxiety and unwanted thoughts would be a good idea.
Sure.
In OCD, it is really not a good idea. It's a bad idea, because what you wind up doing, and the phrase I like is, the more you shove this out the door, the more it's coming in the window. So I get temporary relief from my fear. I get temporary relief from my thoughts. And then the next time they occur again, which they will, it's inevitable, you're going to want to do the same thing. Now I'm on the treadmill of OCD, and the getting rid of it is what's reinforcing it. So this whole process of basically you wind up getting the very thing that you don't want by trying to evade it. And the reality is that the better task, it's inherent. If the thing you're worried about is not inherently dangerous, your best bet is to tolerate the discomfort and go about your business. There's an old Tom Petty song, which I love. And the refrain is, most things I worry about never happen anyway. So we're trying to get people to take that Tom Petty stance, which is, you let things come, you let things go, you stop trying to fuss with your internal workings and dialogue, and if it's not worth your time, you just let it go. But people will often ask then, well, what am I supposed to do when the thought recurs? And my answer is nothing. What am I supposed to do? Nothing. Efforts you're making now to get rid of them are bringing them back in spades. We don't want that. I'd rather you kind of chalk it up to an unwanted, intrusive thought that most people get, and let's not make it worse. Let's not do the things that make it worse.
So ignore it.
Pretty much.
Yeah?
Yeah.
So, all right. Now, I'm a parent. As a parent, is there a way you can see this in your child? Like the cleaning or the worrying about germs and things, maybe that's obvious, but are there other subtle things that you should look for?
That's a good question, too. I would say that the first place I always encourage parents to look is at functioning. So kids, being a kid, you're learning about the world. You're learning that there are scary and dangerous things in it, and there are things that you don't wish to experience. And so kids are navigating this all the time. And most kids navigate it successfully. Most kids have fears. Most kids learn to confront their fears if they're not realistic, and they function quite well. The kids with OCD, I'm always asking parents to look at functional impairment. So if my kid says they're afraid of something, do they then avoid it?
Hmm.
If my kid says they don't want to go to school tomorrow because they might get sick and throw up, do they then not go to school? Or do they say, I'll deal with it as I go? And I think, or a kid who says, I'm not sure I did my homework correctly, are they going to stay up for another hour and check it to make sure, or are they going to let it be? It's funny because a lot of parents are like, that sounds like a good problem. Well,
Right.
it's not a good problem if it's 11 o'clock at night and your kid's asking you, are you 100% certain that I did problem 12 correctly?
Right. They're redoing it over and over.
Yeah. Yeah. So, and some of these traits might even be things you'd want a kid to have. Nothing wrong with a kid who likes a nice clean room, except when it's resulting in them doing laundry every day,
Mm.
demanding that you come in and vacuum with them, and then being unwilling to have people come in and share their things because they don't want to get them contaminated, they don't want to get sick. It crosses over to now being a point of dysfunction. So I want parents to look at dysfunction. I want parents to be looking at hesitation to do what most kids would customarily do. And some parents have a good frame of reference. They've got older kids. Some parents are involved in, if they're teachers or if they're mental health counselors, certainly have an advantage. They know kids well. But if you don't know kids well, it's sometimes hard to know, like, is this normative, or is my kid struggling in a way that's above and beyond? And I'm always looking at, are they being successful? Are they doing well socially? Are they doing well with friends? Are they doing well at school? Are they doing the things that we need to be done in the house? Or are we now getting to the point where their fears are interfering with their ability to do what kids need to do? Now I'm looking more carefully.
Mm. Right. And you touched on it a bit, but living with OCD, what does that look like for the child and also for the family?
Yeah, really, really interesting. So with a kid with OCD, you're often going to start seeing functional impairment in school, functional impairment at home, functional impairment in sports, or in their hobbies, whatever they're pursuing. They stop pursuing things because it starts getting in the way.
Mm.
You may not see that immediately. You may just see reticence and hesitation, and reassurance seeking is another thing you'll see. But I think where it starts to blend in with the family is a term we use called accommodation. So where the families start to basically try to make the world easier. So this is a kid who has trouble with, in particular, has trouble with, trying to come up with a good example, has trouble with getting their clothes laid out because it takes them so long in the morning to make a decision. So they're kind of weighing the pros and cons of non-essentials.
Mm-hmm.
So it's making them late to school. Well, it sounds like a nice thing for a parent to do would be, let's just lay out the night before. Let's get the outfit done, or I'll pick, or I'll find some way to make it easier for you,
Right.
which will probably save you time.
Sure.
But all you're doing at that point is you're punting. So you're moving, you're kind of kicking this thing down the field, and the kid's not learning how to deal with it. You're not learning how to deal with their distress, and their distress is now driving efforts you're going to make. And next thing you know, you're walking on eggshells. I have patients who can't go to the kitchen because it's contaminated. So the parents bring the meals up to the kid's room in the second floor, so they don't have to eat around people who could be contaminated. The kid eats, but now I'm setting myself up to be basically running a hotel and
Right.
teaching my kid that when you have things that are difficult, you should work around them. There's this is a Robert Frost phrase, not sure which poem, but he's talking about the woods, but he really wasn't. And what he said was, the best way out is always through. And with accommodation, parents kind of come to the conclusion the best way out is around. And sounds like a good idea until it's not.
Right.
I want to
Right.
get parents into the mindset of you can acknowledge, you can recognize with your kid that these things are hard, I'm sorry you're having a hard time with this. One phrase that I like to teach parents pretty early, and with OCD, you may already see a combination even when they come in the door. But with parents, one of the things I'm trying to get them to do is ask the kid, like, I wonder how we could manage this differently, as opposed to I'm going to do everything that you ask me to do, as opposed to yelling and screaming at them for wanting things that other kids don't want.
Encouraging them to face it, really.
Precisely. You got to face it down somehow.
So, do we know what causes OCD?
I'd say that there's a complex interplay between genetics and environment and other biological, neurobiological factors. I don't think we've pinned it down. My guess is that if you look at the literature in OCD, you're looking at anywhere from 50 to 100 different genes that interact at various time points. What I would say, given that it's a complex biological soup, there are probably some people more vulnerable than others. It would not surprise me one bit. We've seen this. It tends to run a little higher in families, and that could be genetics. That could be environment. We teach kids how to manage these things in their lives, but they're watching us. They're always watching us. And so if we're reticent, or if we're avoidant, or if we're too fastidious, the kids generally, and especially the vulnerable kids, are going to be more likely to try to walk in those same footsteps. And this is how we do things in our family. And the next thing you know, you got a biologically vulnerable kid learning. The modeling is taking place. But we also know, just from a standpoint of maintaining variables. So there's a lot of kind of causal etiological factors, some of which you control, a lot of which you don't. But what I would say is this: when they start engaging in compulsions and avoidance behaviors, that's the fuel. That's the maintaining variable that we're going to need to help people to reduce and ultimately eliminate. The treatment for OCD is a cognitive behavioral intervention known as exposure plus response prevention, which, and you can make that sound complicated. It's not.
It sounds complicated.
But it's not. Here's what it is you've got to lean into the things that make you uncomfortable, thoughts and situations and et cetera. That's the exposure part. The response prevention part is reduce and eliminate avoidant behaviors, including rituals. Compulsions and rituals are the same thing. But you reduce those and you encourage approach, now you're going to get somewhere. And I don't think you're necessarily going to eliminate fear. Because of those biological vulnerabilities, you may not eliminate it, but you may kind of positively impact the kid's ability to function, to deal with it. And so they may have a fear, but having a fear in and of itself is not even relevant. What's relevant is how do you deal with it. I'll give you a good example. And this is, I spent a lot of time coaching baseball and softball when my kids were young and they liked the game. So it was sort of a thing we did together. So at one point, I drafted just so happened, we drafted a lot of left-handed hitters on my son's 12U team. Sure. And what happens at 11 to 12 or 13 years old, in boys in particular, is you'll see people hit the growth spurt in that range. And so we had drafted a team, had a bunch of left-handed hitters, maybe like 6 lefties. And there was a kid in our league, and he was 12. He was, legitimate 12-year-old playing in the 12U team, but he was about 6'1", and he had a wingspan like a condor. He was a big kid. I suspect he had a handlebar mustache. He looked like an adult, and this kid threw hard. And when you're 12 and you're first learning how to pitch, you might throw really hard. You may not have very good control. Right. So my kids were watching this in a preseason workout, and they were already talking about it in practice. Oh my God, what if we play the team that Leo's on? Well, lo and behold, our first game is Leo, and the kids were like thinking about quitting because Leo threw hard, and they watched some of the damage that he was able to do. Yeah. And so what do? So I can't tell Leo not to throw hard. I can't tell Leo to have pinpoint control. Although that would be lovely. So what I did instead is I got my kids used to it. So I came to practice the first time. I said, okay, we're getting ready for kids throwing and not always knowing where it's going. You need to learn how to protect yourself. So I showed them. I'm a left-handed hitter myself, so I know what to do. So when the ball's coming at you, as a hitter, you pull your hands in here and you turn your back. Because if you're going to take a baseball, off of yourself, it's far better to take it off your back than it is off your wrist. So I sat there and threw wiffle balls at the kids for 2 hours. I did nothing but that in the entire practice. They came back on Wednesday. There's 3 days a week practice. They come back Wednesday. Now I've got rubber balls. And I'm a little bit further back, and I'm throwing rubber balls at these kids, doing nothing but teaching them that they can tolerate it, and teaching them nothing but they have the skills to manage it. And by the time we got to Friday, we started having our coaches throw hard inside. And oddly enough, most of the kids kind of got used to it. And we went out there on Saturday. We lost to Leo. He was really good. But none of our kids bailed. None of our kids left the batter's box. None of our kids, wished they were elsewhere and demanded to go home. Right. So that's I taught them to lean in, not metaphorically and literally in this case. Lean in. Don't act on these fears and learn how to manage this, and you find out that maybe it's not as bad as you thought.
And a kind of a gradual.
Precisely. That's with a wiffle ball to rubber ball to baseball. That's the hierarchy. And right. I didn't tell them it was a hierarchy. I just said I'm going to throw balls at you. And when I throw, you get hit in the back with a wiffle ball, it doesn't hurt that much.
Right.
Hit in the back with a rubber ball with a coach who played, so he can throw it pretty hard. It hurts, but it doesn't hurt quite like a 96-mile-an-hour fastball inside.
I'm just imagining the parents watching practice going, the coach just keeps beaning all the kids.
I had one at the end of the last practice. I had one kid who, fortunately for me, it was my across the street neighbor's kid, and Dad
so he knew you.
So Dad came to pick him up, and the kid walks up to Dad, very proud of himself. And he pulls up his shirt. He goes, "Look, Dad, welts."
Oh no!
And John, my friend, is like, "Good job, True. It looks like you hung in there."
Yeah, sure. He knew what you were working
as opposed to, we're gonna sue you. And I tried to make it clear to the parents what I was trying to do.
Yeah.
At the same time, we have to let people sort it out. We have to let kids sort it out, and we let coaches sort it out with them, because the coaches are experienced and know this. And it just so happened that they were getting their first 12U practice from a very experienced exposure therapist.
Yeah, right. And we will be right back. Real quick, I wanted to take a moment to talk to you about WISE, the Initiative for Stigma Elimination. It unites people across the nation to support those touched by mental illness and addiction. The compassionate approach champions personal stories and powerful connections, fostering healing by reducing stigma through evidence-based practices. Rogers Behavioral Health supports the work of WISE through their Community Learning and Engagement Department. WISE collaborates with a diverse network of organizations and individuals united in the fight against stigma. You can learn more about WISE, explore their 4 key programs, and connect with them by visiting the website www.eliminatestigma.org. And now back to the interview. So, okay, part of your title, OCD and anxiety.
Yes.
Differences, similarities between OCD and anxiety. They're not the same thing.
And they're not. Diagnostically, they're not. And I would say this, that OCD was at one time characterized formally as an anxiety disorder. It got kicked out of into its own category because of what I'm about to say. So anxiety is part and parcel. There are some people with OCD who talk more about discomfort, but a lot of times the majority of OCD cases, and I'd say this is probably the vast majority of adults and the majority of kids, describe that there's some feared consequence. I'm afraid this will happen. And so that piece looks like other anxiety disorders. Social anxiety, I'm afraid I'm not going to make a good impression. Specific phobias, I'm afraid the dog will attack me. Panic disorder, I'm afraid of my own internal sensations. So that there are a host of things that they're common in the anxiety, and the physiology of anxiety is pretty common across all of these conditions. What I would say is the main difference is, what do you do about it? There are people who are, everybody across every anxiety disorder, almost by definition, is avoiding some way.
Sure.
In OCD, there's this more specific compulsive process. I do something active to avoid. I take an hour-long shower when I get home from school. I check my room door and my check my locker, and I check my windows repeatedly in response to that fear. Some kids will just sit there and worry, but kids with OCD, they tend to take the bull by the horns and do active things to try to get rid of the fear. And again, that's the very process that's maintaining the fear in their case.
So I guess if someone's coming to Rogers for OCD or anxiety, is the treatment similar?
Yeah. I would say, I mean, and there's a few things I would say first. First off, if you're coming to Rogers, in all likelihood, based on the research that we've done, in all likelihood, you've had prior treatment. You've had either cognitive behavioral treatment or medication or both, and you're still symptomatic to the point where it's so much in the way somebody thought you were a candidate for higher levels of care.
Right.
So already I'm further down the funnel in terms of severity.
Sure.
So at Rogers, I'm going to see those kids. And what I would also then say is when you come in and you have OCD, there's an OCD and anxiety track, which implies that we're going to do similar stuff. But what I'm going to figure out as a therapist and as a supervisor, okay, a diagnosis tells me, if somebody has a diagnosis of OCD, it tells me to look for compulsions. What are their compulsions? If they have a diagnosis of social anxiety, I know the situations that are likely to be fear evoking. I'm assuming they don't have a ton of compulsions. I'm assuming they just avoid. And so then my hierarchy, which I just described what a hierarchy was, of low, medium to high, things that will provoke a little bit of fear, some fear, and then a lot of fear. I'm going to try to make a gradual ladder, if you will, of those situations, and I'm going to encourage the patient. We're going to try to take on the easier stuff first, move our way up. And if you're and in OCD, what I'm also having to do is I don't want to just confront situations that provoke fear. I want to provoke those. I want to kind of evoke those situations, put them in those situations, and have them also refrain from compulsions. Because if I do an exposure where I touch contaminated stuff and the kid washes their hands or they rub their hands literally as I'm doing the exposure, it's probably better than doing nothing, but it's not nearly as effective as touching the gross thing and then getting it all over you. That's probably better than touching it and then washing or the wipes that which became very popular over the course of the pandemic. Or those gels that you use, hand sanitizer. When I see hand sanitizer in an OCD kid that's got contamination fear, I already know that stuff's got to go. We got to get that out of here because it's going to make their fear. It's reinforcing the fear.
Right.
They conclude that the reason I'm not sick is because of this, as opposed to the likelihood is that you wouldn't get sick anyway. Let's go find out.
Sure.
Let's go find out. I've rolled across the train station bathroom floor in Philadelphia more times than most people, and I still managed to be reasonably healthy.
And here you are. Yeah, look at you.
Yeah, I'm still around. And someday I may be wrong, but I'm willing to roll the dice now because I've been at it for 32 years. So
yeah, right.
I'm feeling pretty confident.
I say rolling around on the bathroom floor might be kind of part of the answer to my next question, but how can parents help support recovery? I mean, is it setting examples like that, or?
I think there's a modeling piece to maintaining the fear. There's also a modeling piece to modeling courage, if you will. So anytime a parent is doing something they don't want to necessarily do, but they have to do, my inclination would be to make note of that. Or if they make a mistake and they point out to their kid, I made a mistake today at work, a kid who's perfectionistic might be interested in that. So that you want to support the kid moving forward and confronting situations that provoke anxiety. With the younger kids, I tend to be even more formal about that. Like you can earn certain rewards, if you will. We set that up in our behavioral plan. So if the kid comes to session, comes on time, does their exposure practices, they can earn stuff, if you will, because kids like stuff.
Yeah.
And older kids, I think the older kids like the respect of their parents as them being autonomous beings. So I want to encourage kids to be independent in the treatment and not just have it dictated by the parents. So that's an important thing that parents can do. But what I would say in general is I want to encourage my kids to confront situations that provoke anxiety and simultaneously reduce and eliminate any compulsions. I can work. This is a story that I don't know. Maybe it doesn't put me in the most fabulous light.
I can
So
always edit it out. Go ahead.
yeah, you'll decide later. So my 17-year-old, who was very good student, but she's also public speaking was not her thing at the time, and she got selected to be part of a debate in class, and the debate was about a book that she loved. And so she was on the pro book side, somebody else was on the anti book side, and she was selected by her teacher, and the teacher knew her and basically said, look, I realize, Delia, that you're not going to want to come to school that day. Understand something. I know where you live. And if you're not in class at 8 in the morning, I'll check the record. I'm coming to your home to drive you here. So she knew. And so I'm at a conference in Chicago, and Delia texts me, and I knew the timing. I was about to give a talk in Chicago. She's about to give her debate. And I'm looking at my phone, and my phone says, and Dee's a pretty dramatic kid still, and the phone says, it feels like my insides are rotting out. It's like she's having a panic attack, getting ready to take this on. My response, as maybe a direct dad, but not always the kindest, my response was, that's all well and good. Now go do your damn job. And I left it at that. 2 hours later, I get another text, and it says, and in caps, it still feels like my insides are rotting out. And my response says, oh, fair enough, but how did you do? And the response she fashioned, which I'll clean up for the podcast, her response was, I freaking roasted him. And my response to that was, that's my girl. And so many years later, we're having a conversation, and I looked, I said, D, you mind my asking you a question? Why did you text me instead of your kind and loving mother that day? And she thought about it. She said, well, because I realized that what I needed was a shove, not a hug.
So that's kind of treatment.
Yeah, but I think you can do both. You can provide a lot of positive reinforcement. You can provide all the social reinforcement. You can provide the hug. But in the middle of it, I want you leaning in. You got and for every kid who ever turned around and looked at me when they were facing a tough pitcher, when they're walking from the on-deck circle into the batter's box, they turn around, look at me, and my reflexive response was look them dead in the eye and say, you got this. You got this. I'm not even telling you whether you're going to get hit or not, but you got this. Let's get.
I feel like that's good advice for any parent.
Yeah, I would think so. And one thing I've as a parent I got pretty good at was when my kids would come with various problems. And some of the problems were minor, some of them were not. When they come to describe a problem for me, the first thing I would say is that sounds like a pretty big one. What do you think you can do about it? As opposed to let me rush in and save you. Let me help you avoid. I've heard this said that the dean of students at Loyola University in Maryland gave a presentation at one point and talked about snowplow parents. Not helicopter parents, but snowplow parents.
Yeah, you're going to have to explain that for me.
Well, and the helicopter parents are the ones who just hover.
Yep.
The snowplow parents are the ones who try to get the snow out of the way before you have to drive. And the problem with that is I've learned nothing about managing the snow. I've learned nothing about what I can do.
Sometimes you didn't even know it was there. Right.
Precisely. I want to teach you to deal with the things you're going to have to deal with. So let's figure it out. Here's how I manage this, and let's give it a little try. Let's give it some practice. See how you do. And if it's an interpersonal thing, I might even role play it with them.
Sure.
Let's pretend you're not happy with how the coach talked to you about this or how the teacher talked to you about this. Let's walk up and pretend I'm the teacher, and you tell me what do you think the best way to do this is going to be, and we'll practice it.
Right.
Because I'm trying to model for them what I want them to do, and I'm not gonna do it for you because I'm not doing you any favors. If I'm doing it for you, I'm not doing you any favors. You're not gonna learn a thing. In the end, I think people learn best from their own experiences, and that's why I don't spend a lot of time when I'm doing these exposure treatments telling people it'll be okay, telling people that it's going to be fine, telling people that everyone survives this, giving them extensive statistics about how dangerous this actually is. My language, and I cut to it. I said, well, all I can tell you is this: I would do this. I also I like your odds, but of course there are no guarantees. What do you say we go find out? What do you say we go find out? That's what I'm trying to do. Let's go find out. Well, I don't know. And if it's inherently dangerous, I'm not going to tell you to go find out.
Right.
If you have intrusive thoughts about getting into a tank with a great white shark that hasn't eaten in a month, I'm not going to recommend exposure. That's a bad idea. That's not going to go well.
Yeah, it's a pretty good fear to have, I think.
You probably keep you around for a while too.
Fairly reasonable.
Yeah.
So what would you say to families or parents or even their kids during setbacks? So let's say someone's on the road to recovery, but all of a sudden they hit a wall.
Yep. Yeah, and I would say that first thing I would say is normalize that.
Yeah.
That's where we're going to find ourselves. And so okay, so that one didn't go as well as we'd hoped. Is there anything we could have done differently? Is there anything we could do next time that can make it more likely that you can stay where you were? I realize this is disappointing, but let's think about how we made the progress we did. Let's go back through it. And I'm not looking for perfection. I'm not looking for guarantees. Some days you got it and some days you don't. And I'm gonna encourage people though to not give up. The only way to really fail at this is to give up. So let's get back on it. If that was too hard, what could you do? That's another thing I'm trying to encourage kids to do. So they touch something they think is super contaminated, and now they can't do it. I'm like, okay, so how would we do this if we were still in treatment? If you were still in treatment, what would your doc have told you? Yeah. Well, and if they're treated by me, they'd probably say, well, Dr. Marty would probably say, let's do the principle of the thing that touched the thing that touched the thing. So if I have a horrible spot on a carpet that could be human feces, although probably isn't, I touch something to the spot, I then touch that to something else, and now I touch the book. In all likelihood, I'm going to get some stimulus degradation. The book is easier than the pen. The pen is easier than the spot. I practice the book. I get to the pen. Now I'm going for the spot. I break it up to make it more manageable. As a coach, I'd see this with kids going in to the pitching machine. And if I have a kid who I'm always counting. I got 20 balls in a bucket. I'm counting how many balls did you hit hard. So if you hit 20 balls hard, next time you're in that cage, I'm turning the pitching machine up.
Right.
My oldest daughter, I stuck her in there at one point as a demo because I knew she could already hit, and I got 11 kids watching, and the first pitch I threw her was probably on a pitching machine going 40 miles an hour. She hit a line drive right in the neck at me, so it hit me right in the neck, which was not fun.
Right. And
my daughter's tough as nails. She's like, "Are you gonna go through the rest of the bucket? Or are you just gonna lay there?" Like, I'm coming. Give me a minute.
She learned from her dad.
Oh, yeah. She's a tough kid. So if you're hitting 20 out of 20, I'm moving it up. If you're hitting 10 out of 20, I'll probably leave it where I am until I can work on your swing a little bit and your confidence. If I put 20 balls through and you hit none of them, I think the best way to get a kid never to play again is to put it up 5 more miles an hour. Like I'm going to demoralize you. So I'm going to turn that down. I'm going to figure out what's going on. I may have you hitting off a tee until I can figure it out. And once we figure it out, now I'll move you back in. So if something is too hard, what along the path could we do that will get us there? Doesn't have to be this minute. And oftentimes when kids start to kind of regain their sense of confidence and understanding of principles, they're going to get there when, they're going to tell you, all right, turn it up. And that, I think that's true of anything. Academics, it's true of just about anything you could imagine, where if something proves to be too hard, continuing to do it without changing our skill set maybe isn't the best way to go.
Sure. Yeah, that makes sense. So I guess my last question really for you, it's not even so much, I guess it is a question. Uh, Seeking treatment can be scary for people. So
Sure.
you're a parent, you see some telling signs in your child that maybe something's going on.
Yep.
Like, what do you say to someone taking their first steps towards finding treatment for, a child or a loved one or themselves?
Yeah. I'm a scientist. That's the other hat that I wear. And so the first thing I want to know is, if I'm for anything, is the treatment effective? And then in order to answer that question, I need to know what the science is. What do the experts think? So I'm going to try to find myself somebody who's doing something that has some empirical support to it.
Mm.
And if that's in my wheelhouse, it's easier for me to do. If it's not, I'm going to ask around. But I would say that an organization like Rogers or an organization like the International OCD Foundation can help somebody to be more discerning about what treatment they should get.
Well, and I think, I mean, light at the end of the tunnel, it's treatable, right?
Oh,
Like,
100%. And
yeah.
and I would say that the treatments we have, cognitive behavioral, serotonin reuptake inhibitors in combination, the vast majority of folks, and including kids, who receive those treatments, generally speaking, experience a reduction or a significant reduction in their symptoms and maintain their gains. It doesn't mean perfect. It
Hmm.
means, though, that you've developed some approaches and strategies and understanding of this illness and how it works. And you don't want to give the illness what makes it worse. You want to confront the thing, and you can keep it at bay really quite well. It can be a pernicious and functionally impairing condition, but when you get the right help, and you trust that help, and you work the program together, and all of that, your outcomes are likely to be quite positive.
Well, Dr. Franklin, thank you so much for taking the time today. This is all really great information. I really appreciate it. Thank you.
Oh, sure.
Listener, thank you for joining us as well. I hope you found some of this information helpful, reassuring. I know I learned some things from Dr. Franklin that I'm going to take with me. Thanks again. Like, subscribe, all that business, and we'll see you next time. As always, if you or someone you care about is struggling with a mental health or substance use disorder, visit rogersbh.org for a free mental health screening.